My name is Matt Beth, and the article that I wanted to tell you about today is Levodopa facilitates improvements in gait kinetics at the hip, not the ankle, in individuals with Parkinson's disease by Sydney Baudendistel, Abigail Schmidt, Ryan Romeek, Isabel Harrison, and Chris Haas. Dr. Chris Haas is the principal investigator for this study and is an associate provost for academic affairs and faculty affairs at the University of Florida. He was formerly a professor of applied physiology and kinesiology in the College of Health and Human Performance at the University of Florida, where he also received his PhD. He is an affiliated faculty member at the Fixel Center for Neurological Diseases. Further, he is the director of the Applied Neuromechanics Laboratory at the University of Florida. Sydney Baudendistel is a doctoral student at the University of Florida, studying biomechanics under Dr. Chris Haas. A couple of main takeaways from the article were that there were drastic improvements in step length, walking speed, walking time, and hip flexion torques when on medication. This study did not analyze the knee, as it does not significantly contribute to an individual's forward progression during gait. The second thing to take away from this article is that the most significant improvements yielded by Levodopa were seen at the hip, while only minor changes were observed at the ankle. It is estimated that approximately 60,000 people in the U.S. are diagnosed with Parkinson's disease each year, and worldwide 2.5 million people are currently living with Parkinson's disease. Parkinson's disease is a result of a complication in the brain. Specifically, this occurs in a part of the brain called the substantia nigra. In the substantia nigra of a person with Parkinson's disease, cells produce an insufficient amount of the neurotransmitter dopamine. This leads to a plethora of cognitive and physical impairments. When thinking of the physical symptoms associated with Parkinson's disease, people most commonly think of someone with the physical qualities of the person in the picture on the far left. In reality, though, as the picture exemplifies, people living with Parkinson's disease have a wide variety of severity, and thus a wide variety of impairments. However, Parkinson's disease commonly hinders spatiotemporal gait characteristics, thereby reducing step length and overall gait speed. In fact, the article explains that in comparison to healthy peers of the same age, people living with Parkinson's disease exhibit walking that is 30% slower, and the decline of their ambulation is exponentially faster due to the progression of their disease, in comparison to the detrimental degradation of normal aging on an individual's ambulatory behaviors. This is critical in daily situations. It was pointed out in the article that individuals with Parkinson's disease may not be able to walk quickly enough to safely cross the street during the programmed crosswalk time. So, what is Levodopa? Levodopa is the most potent oral medication for treating the physical ailments of people living with Parkinson's disease, and it comes in a variety of different pill forms. Treatment with Levodopa is widely considered to be the gold standard treatment for people who have Parkinson's disease, enabling them to achieve quicker and safer ambulation. The experiment analyzed kinetic and kinematic data from 13 participants with Parkinson's disease that were currently taking levodopa. A series of 2-day exercise sessions were implemented for the study to examine the difference made in different gait variables from utilizing levodopa. The study divided the participants into 2 groups. There was an on-medication group, and the remaining participants were assigned to the off-medication group. Members of the off condition on the first day of the experiment were in the on condition on the second day of the experiment, and vice versa. The on condition consisted of participants that were taking their regularly prescribed dosage of levodopa. Conversely, the off condition consisted of participants undergoing a 12-hour levodopa withdrawal. The sessions occurred at the same time each day, and participants would walk on a treadmill for 5-minute bouts. Data was collected from the participants during the last minute of their 5-minute trials. The treadmill speed was selected without regard to medication status or overground walking pace. Overground pace was derived prior to the experiment by having the participants walk along a 12-meter walkway at their desired, most comfortable pace. Logically, a treadmill was used for the treadmill trials. However, a standard everyday treadmill was not used. The experimenters used a split belt treadmill, which has 2 belts that can travel at different speeds. This enables the researchers to capture force data independently from both the left and right legs. To analyze the kinetic and kinematic data from the participants on the treadmill, a 7-camera Vicon motion capture system was used. Much like the picture, prior to the treadmill trials, 35 retroreflective markers were used to capture and analyze the data by the Vicon motion capture system, and the 35 markers were strategically positioned on each of the participants. This bar graph depicts the data from the study regarding various spatiotemporal ambulatory variables. As you can see, the implementation of a routine levodopa regimen increased both the treadmill speed and the step length of the participants. Meanwhile, the introduction of levodopa led to a decrease in step time for the participants. These alterations sum together to enable those taking levodopa to have a quicker and safer gait pattern. These bar graphs depict the peak force data from participants taking levodopa or not, which was observed in the study. As you can see, this data encompasses different measures of force and power from various parts of the body. The greatest improvements by those taking levodopa were seen in the hip flexor moment, the hip extensor moment, hip power generation, and hip power absorption. From this, it is easily declared that the greatest benefits for peak force kinetics by those taking levodopa are observed at the hip. So just to reiterate, when taking levodopa, there were notable improvements in step length, walking time, and hip flexion torques, all resulting in an improvement in walking speed that is much safer. Further, the greatest improvements from taking levodopa were observed at the hip, including the hip flexor moment, the hip extensor moment, hip power generation, and hip power absorption. The moments are best defined as the amount of rotational force yielded about a specific joint. In this case, the greatest increases in force production were observed about the hip. In In the future, research should focus on two main areas. First, research should focus on improving the rehabilitation of impaired force production at various joints. As we saw, Levodopa improved force production qualities at the hip, but not so much at the ankle. Second, research should be devoted to bettering joint kinetic redistribution. Joint kinetic distribution refers to the interaction of forces through the moments developed about different joints. Thus, the term redistribution implies how Parkinson's disease leads to alterations in the aforementioned force interactions and therefore must be restored to how the forces behaved prior to being negatively affected by Parkinson's disease. Improving both of these things in conjunction with one another may result in the development of new therapeutic interventions, with the ultimate goal of improving an individual's independence and degree of mobility. As I wrap up, I just quickly wanted to say thank you for your time and attention and for the opportunity to tell you a bit about this article.